coming. Thank you. This is, I think, a very important topic for our state and certainly our country. As the press release went out, it was Obamacare and you. And some of us like the legislation, some of us don't, but I think it is here and there's some very good parts of it, and this is what we're going to learn about tonight, is how it impacts us all. Just to outline, the official act is called the Patient Protection and Affordable Care Act, also known as Obamacare. It was signed into law by President Obama March 23rd, 2010, and it does represent the most significant government health care policies since Medicare and Medicaid in 1965. The Affordable Care Act is aimed at increasing the rate of health insurance coverage for Americans and reducing overall costs of health care. Those are the main goals for that. It provides a number of mechanisms, including mandates, subsidies, and tax credits to employers and individuals to increase the coverage rate. Additional reforms are aimed at improving health care outcomes and streamlining the delivery of health care. Some states are choosing not to set up the exchange. I know 2 years ago, I believe it was 2 years ago, we did set up in the legislature, we did set up the mechanism for setting up the health exchange, which is a marketplace for uninsured and people who need insurance in the state, and Kevin is going to be in charge of that. Anyway, the goal of this forum is to educate you all on how this legislation impacts all of us personally and on a state level. We have two panelists. Maura Carley is founder of Healthcare Navigation, and Kevin Counihan is the CEO of Access Health Connecticut, which is the exchange here in Connecticut. Maura Carley, Masters in Public Health, and CIC, which is an insurance designation, thank you. A lot of initials. We live with initials and acronyms up in Hartford, and there's always a new one every day. Anyway, Maura is president and CEO of Healthcare Navigation and has an extensive background in healthcare. She founded Healthcare Navigation, a patient advocacy firm, in 1999 after years of senior management experience in hospitals, HMO, and physician practice management organizations. Maura is also a newly appointed member of the Access Health Connecticut Board of Directors and a longtime Darien resident. And I'm always happy to share my personal experience with Maura. Great book, Navigating Insurance, Navigating Traps and Gaps. Bestseller on Amazon. You can get it at Barrett Bookstore.
Or take it out of the library.
No, the Barrett Bookstore, small business. I've given it to a lot of friends and they've loved it. Anyway, Kevin Counihan was chosen by Governor Daniel P. Malloy to serve as CEO of Access Health Connecticut. He has worked for 30 years in healthcare and health insurance, most recently as president of Choice Administrators Exchange Solutions in Orange, California, which assists states in creating health exchanges by 2014 as mandated by federal healthcare reform. Kevin also mentioned to me that he set up under then Governor, Massachusetts Governor Romney in 2006, that healthcare exchange. So we've got lots of experience up here, so I will turn it over to them. Questions and answers after they are done presenting. And the only thing I will ask is, this is an informational forum, it's not a political forum. So in good spirit, if you don't like the legislation, this is not a venue to air that. So I hope you all understand that. Thank you, and Maura and Kevin.
Thank you. I'm delighted to be here, and I do a lot of speaking, but tonight I'll have one of the shortest rides home ever. I brought a guest this evening. This is the Affordable Care Act, and very few of us have read all of it, but I wanted to bring it to show you that reducing it to about 10 slides is absurd. But nonetheless, that is what I've done this evening. But before we even go there,
Speak to the mic, please.
Here.
Can you hear me?
There you go.
Better?
Yes.
Okay, that's better. Well, I'm not at feedback if I have both. Is this good?
Yeah, there you go.
Good, okay. Feast or famine. Feast or famine. In our business, we see all the time that people tend to not learn very much about healthcare coverage until someone in the family is sick. And that's because most of us don't utilize a lot of healthcare services when we're healthy. We're very moderate utilizers. Employers or Medicare's often paying the bulk of the bill, so we're not really very interested in learning about health insurance. So tonight, I wanted to take a few minutes before we dive into the Affordable Care Act to try to help people understand how did we get here that this massive legislation would be enacted. So let's go back. I'm going to make some of this personal because I know my life better than anyone else's, but and also because it resonates. People remember things. All of my, well, I shouldn't say all, my parents and my in-laws, just 4 of them, all born between 1925 and 1930. Now, all born in major urban centers, 3 in the Northeast, 1 in Chicago, all born in hospitals and delivered by an obstetrician. And how is the bill paid? Cash money. No insurance. So we've gotten to this dilemma of ours just in modern times. So I want to walk you through, I see the 60s, 70s, and 80s as a time of tremendous transformation. And we're probably on the verge of another era of transformation. But let's go back and just briefly see the history of insurance. There's not agreement on how it all started. One group thinks it was the Dallas teachers who banded together and decided, let's pay into a fund and help pay for hospital care if we need it. That was 1929. That's a good enough example. So that's when all of this began. So we have the 30s and the 40s. In the 40s, we have World War II and price control. So that's when group coverage started to truly take off as a benefit being offered. And don't worry, we'll get back to that. A benefit being offered because of the price controls. And the same is true, evolution in the 50s. What I would submit is that in the 50s, most medical services were probably still largely affordable on an out-of-pocket basis. And why do I say that? I will show you. I have a hospital bill from the 50s. In fact, my hospital bill at birth. And in 2011, my mother passed away, and she had a cancer diagnosis. And curiously enough, she saved, I'm one of 7 children, she saved a manila envelope full of things for each child, and she didn't tell us about them. So as my sister and I sat there looking at these things, everybody else had artwork. I love you, Mom artwork. My envelope, a hospital bill. So I was stunned initially to think how bad an artist I must have been. But after I thought about it, why on earth did my mother save a hospital bill? And I was born in July, and I'm in my late 50s, but not for long, so you can figure that out, 1953. And my father was a resident, and I think he had just finished his residency and not started his, or maybe not, just finished his internship and not started his residency. So I think my parents paid this bill. This is my only theory I can come up with, and it's a pretty good one, that my mother would have saved the bill, but have never told me to not want me to feel badly about it. But what did my parents pay for 7 days for mother and child? Remember that? That was the standard of care then? 7 days for mother and child to be in the hospital, discounted to $138. And if you punch that into a CPI, inflation calculator, consumer price index, oh, that's a different one. excuse me, I really need my glasses. In 1953, $138. Well, fast forward to today. That in 1953, in 2013 dollars is $1,203.10. $1,203.10. Now that would still, that's not insignificant, and you would still have to pay the obstetrician, but it's not ruinous. I don't think anyone would call $1,200 ruinous. So let's leave the 50s behind and get to the 60s. As Terry mentioned, Medicare and Medicaid passed in 65, implemented in 66. And why? Because as a society, we're always trying to do good and extend access to our people. And who was overlooked at that point when you had a predominantly employer-based system? The lower income people and people who were no longer employed. So Medicare and Medicaid, 1966. Let's fast forward into the 70s. I started graduate school in 76. And I have a master's in public health from Yale. In 1976, my textbooks were describing healthcare as in crisis. And you can go back and pull out passages from things that I was studying and reading about in the late 70s that you could just apply to today. Because we got what we asked for. What happened and what those Dallas teachers probably didn't think about was that health insurance is different from other types of insurance. We don't want to use our auto, and we don't want to use our homeowners, but we want to use health services. And theoretically, health services could be unlimited. So we have this dilemma of increasing access, and then I also worked in the insurance side of the business. Insurance people say benefits drive utilization. So that's what we have. Benefits drive utilization, which increases cost, which makes premiums higher, and for the people who have to pay them, more unaffordable. And so we've been struggling with this dilemma for decades. In the 70s, we had major federal legislation. And I spent a lot of money in graduate school studying some failed federal initiatives. But let's go through them quickly, and I'm going to be describing massive legislation in little sound bites. But in the early 70s, we had the establishment of PSROs, Professional Standards Review Organization. And again, all of these initiatives are because, oh my gosh, we passed Medicare and Medicaid, and then it cost us so much more than we expected, and taxpayers are unhappy. We got to do something. Professional standards review organizations were largely, okay, the federal government's now paying for a lot of people to be in the hospital. Let's make sure they're supposed to be there. Okay, utilization review, concurrent review. The HMO Act of 1973 actually intended to nurture the development of those nonprofit staff and group models that aren't around much in this part of the country anymore, but instead led to a whole new type of health insurance company. Do you remember commercials from the 80s, US Healthcare and the Apple, and whatever one Dick Cavett was advertising, an Oxford Health Plan? Then right after that, we had huge, what was it called? National Health Planning Development Something Act of 1974. That was a remarkable piece of legislation because it totally countered the Hill-Burton legislation of 1946. Hill-Burton, basically, the war was over and the mantra was, this is the United States of America. Let's build the biggest, best hospitals in the world, and we're going to have a beds per thousand population ratio of 4.5. That was the US goal. Less than 30 years later, the federal government is saying, essentially, oops, 4.5 beds per thousand, too many, An empty bed somewhere is a bed that can be filled that we might have to pay for. New plan. And not only are we going to have a new goal of below 4 beds per 1,000, we're going to try to constrain capital to these hospitals. And when you think of the terminology from some of these eras, the hospital arms race and things like that, so that was to make sure hospitals didn't buy too many CAT scans and overbuild and so on. The most important question I have for you, does anyone remember what happened on October 1, 1983? No?
Oh, that was
Sticking to the healthcare world. But they're all related. On October 1, 1983, the federal government moved to cost-based per day reimbursement of hospitals to DRGs, diagnosis-related groups, essentially revenue per admission based on diagnosis. So think about it for a minute. I was a hospital executive at Stanford Hospital. In September of 1983, what were the incentives financially? Admit and keep the patients. Very simply put. October 1, 1983 with Medicare, admit, keep for 3 days, gotta have them for 3 days before Medicare pays, and then move on. So in the 80s, we had a reaction to the federal government getting better at controlling its liability. And so business was paying more and business reacted. Does anyone remember the birthday rule? Matt,
You get
you
one a
must.
year?
The birthday rule. The birthday rule
If
was,
both parents have insurance, you use the parent with earlier birthday.
bingo. Did people hear that?
No.
If both parents, I mean, my husband and I must have been paying nothing for our health insurance because we both had full family coverage for our first 2 children, born in 1983 and 85. That's where the birthday rule came from. Which insurance pays first for the children? Nobody talks about the birthday rule anymore because employers passed on so much of the cost of providing health care coverage that by the end, I mean, even by 87, my 3rd pregnancy, ooh, it was one or the other. We're paying too much to have double coverage. So I'm going to fast forward now until the present. A whole host of things happened in the 90s. You know, we had business moving people into HMO products, and then we had what? A consumer revolt, right? Remember those terms? Drive-through deliveries. I didn't have one, I had 7 days. My first week of life was my first week's vacation. But drive-through deliveries and, you know, what do you mean my doctor's out of the network? So we had all these other initiatives, but basically, for a long, long time now, we've been dealing with issues sort of at the fringes, and the situation has gotten worse and worse in terms of people not being able to afford health care, not having coverage being potentially ruinous if you need medical services, and millions of people being uninsured. So, now I will go to my 10 slides. And I've lost my glasses, excuse me. And I apologize, all my people who know how to make things pretty had problems today. Illness, so you just have a lot of verbiage here because I don't really like PowerPoint enough to spend any time learning how to make it prettier. This we already covered. The goals of the Act are twofold. Reduce the ranks of the uninsured, but do it in a way that we don't repeat what happened with Medicare and Medicaid. Where are we in Connecticut? We're doing better than the rest of the country. And Connecticut, I'm proud to say, and you should be proud too, has been a leader in a whole host of initiatives. So as opposed to the national average of 16% uninsured, we have about 10. The Health Free Insurance Association, which is our state high-risk pool, which was created in 1975, I think was the first in the country, and there's 30-some. Their future is unclear with all of this, but the point of this slide is to say, it's probably fair to say that Kevin's primary focus and obsession is making sure we get everybody who could benefit from using the exchange, that he's going to talk about in detail, getting them to the exchange. Our other concern is, what about all the other people? Because again, so many people don't even learn about insurance. We've got a state high-risk pool population. It's under 2,000. Those are people who probably, when coverage as of 2014 is not based on health status, would benefit from getting out of the high-risk pool. We've also got Charter Oak. We've got all these people with individual coverage. Tends to be about 5% of the population whose policies are not likely to meet the minimum essential requirements of the Affordable Care Act. And maybe all the insurers will notify them, but it's a very important population to reach. And I'm not going to go through all of these things. I actually have brought a suggested reading list, and if you want us to email it to you, we can do that. I've got an associate's business cards. That way you can just click on the link. But this reading list includes some articles, some books, but also the Access website, the healthcare.gov website, which is the federal website. So there's an awful lot you can get online. But let's just briefly go through some of these changes. The Affordable Care Act created temporary high-risk pools in all 50 states. So that's different from the Health Reinsurance Association. The temporary high-risk pools were subsidized, and you had to be uninsured for 6 months and have a pre-existing condition. All of those are slated to go away December 31st of this year. So that's another population that's going to need coverage. And frankly, I should say that enrollment to them has been closed. Just wanted to comment on the adult children to age 26 being allowed on a parent's plan, regardless of what the right age is. It's just such a wonderful change because it's fair. And we're so happy to be out of the dispute business over, oh, how many units was he taking? He wasn't really eligible for that coverage. It's just horrible. So at least 26 is fair, because before you had to be a full-time student. It got increasingly more stringent to prove you were a full-time student. Ridiculous. So let's just talk in terms of 2011 about insurers being required to meet medical loss ratio targets. So everybody knows what that means. Medical loss ratio is the,
No, I've heard, I don't know what it is.
right, I want everybody to know this. Medical loss ratio is the percentage of the premium spent on medical care. All right? So the Act requires that these are fully insured products, refer to insurance products where you pay a premium and the insurance company is responsible for the claims. Some big companies are self-insured, and that's a different animal. But fully insured products by the Act are required to spend 85% of their premium dollars on medical services. If it's small group, 80%. So that's a huge change. That's a huge change. That means that insurance company profits are controlled, and they've had to give rebates if they didn't meet those targets, and it's much more complicated than that. It is a double-edged sword, because I can tell you from my years on the insurance side of the business, we were very focused on reducing the 85%. not the 15. I mean, also the 15, but the big return was on the 85%. So that's just the double-edged sword aspect of this, plus the fact that the bigger the number, the higher the 15% is. But everyone should know that this act controls insurance company profits. I'm not going into this in detail. I'm assuming many of you are aware that if you file an income tax return that's $200,000 for an individual or $250,000 for a couple, that this year your taxes are going up to help support the Affordable Care Act. Okay? A payroll tax and a tax on unearned income. So, we're up to the big year, 2014. And let's make sure everyone is on the same page about individual insurance, because many people on group coverage have never even dealt with the individual insurance marketplace. That's where you apply as an individual. Today, in 45 of our 50 states, today meaning still 2013, you fill out a health questionnaire when you apply for insurance. And if you've never seen one, it's pretty similar to what you fill out when you go to a doctor's office. And the goal is to be able to truthfully say no. I've never had this, I've never been treated for this, I don't have this, and to have very few drugs. So that's what it means to say individual insurance is medically underwritten. The person applying for it fills out an application, and the insurer has the discretion to deny. That's still where we are today, although the insurance companies are getting ready for 2014 when that goes away. There aren't these health questionnaires, excuse me, that determine whether or not you get the coverage. So they're publicly saying, we're going to entertain more applications from people with the kinds of conditions we wouldn't have entertained in the past. So that's a good thing. But they still have the right to refuse you. And if you're refused in Connecticut, you still have some other alternatives. Of course, I don't know if it's been mentioned already. Yes?
You're saying that even though you're not medically underwritten, they can still refuse you?
In 2013,
But in 2014?
but not in 2014.
Yeah.
In 2014, there'll be an enrollment period, and you have to abide by that. But Kevin will go through that. One of the reasons the Affordable Care Act was controversial was this notion that you've got to have creditable coverage or pay a penalty. And that takes effect in 2014. This is one of the issues that took us to the Supreme Court with 26 states suing. And Justice Roberts upheld the legislation, and he said, basically, Congress has the right to tax, and that's how this was upheld. So that takes effect next year. And going back to my earlier slide, again, one of the things we want to do is get people who have coverage that won't be considered meeting minimum essential requirements into a product that is. Okay, more acronyms. Federal poverty level, the FPL. So we've got Medicaid expansion to a certain percentage of the federal poverty level, and beyond that, we've got tax credits and help with out-of-pocket costs. That's what the CSR refers to. And insurers must offer plans meeting the new requirements. You probably don't even realize this. People who have group coverage tend not to. But most individual coverage does not include maternity care, for example. I think Connecticut is the only plan right now offering individual coverage. Is that right? That includes maternity. As of 2014, maternity care is one of those 10 essential elements that must be included in insurance. And large employers, we'll get to them in a minute, employers over 50 who have 50 full-time equivalent employees must also offer coverage or pay a tax. So let's look at the penalty structure. As you can see, it's very low. It's very low relative to what health insurance costs. So what's the obvious concern? That too many people will choose to pay these penalties rather than seeking the protection of health insurance. Just a brief comment, because this area is so complex. What employers of 50 or more full-time equivalent employees must offer. They must offer minimum essential coverage or pay $2,000 per employee fine. The fines are higher under certain conditions. The coverage that's either not consistent with the affordability guidelines or not meeting the minimum essential requirements. But any employer affected by this really needs needs to consult people who know this inside and out. They're brokers, they're insurance consultants. We don't do this kind of business. And perhaps legal counsel as well. And just so you know, large employers have almost always included healthcare coverage as a benefit. Smaller employers, very different story all over the lot. And again, the smallest employers are exempt from this. But even employers of 80 people, whether or not they offer coverage or whether or not they just offer it to the subscriber or employee, or whether they offer it to dependents at the employee's cost, it's just all over the lot. So it will be more similar with this act. I don't think there's any point in talking about 2018 or 2020 at this point. We need to be focused on 2014. But there are changes throughout the decade, and one that a lot of people have their eye on is in 2018. If the plan is too rich, employers might pay extra. Let's talk about some concerns. Concerns are that premiums increase because we're going to cover maternity. We've got a different rating scheme. The rating scheme is older people can't pay more than 3 times what younger people pay. Right now, rates tend to be age banded at every 5 years. I know that's a lot of terminology, but 25 to 30, 30 to 35, 35 to 40, and so on. So the 3-to-1 ratio is going to increase premiums for younger people, and that is a concern because we desperately want them to get in the pool and have health insurance. Sort of the same side of the coin. Too many young and healthy choose to pay the penalty. A major criticism, somewhat legitimate, is that people can stay outside the system, pay the penalty, and then get back in when they're sick.
No, they can't. No, they
In
can't.
an enrollment period.
No, they can't. Yeah.
In an enrollment period. It's just like how Medicare works now. If you don't get on Medicare in the way Medicare wants you to get on, and wait until the general enrollment period, you have a gap in coverage. So we're moving to something more similar to that. And Medicare, too, doesn't recognize any pre-existing conditions. Same concern on the part of businesses, that they choose to pay the penalty. And I'll let Kevin talk about small businesses. I think this IRS not including spouse in the definition of dependent is sort of a a non-issue, although it's true. The act requires that larger employers offer coverage to employees and to dependents to age 26, but not the spouse. Are we going to see major changes because of that? Probably not. But the fact is that if an employer did leave out the spouse and restructured its coverage offering in some way, that person would be able to get coverage. But larger employers are likely to continue to offer coverage as a benefit, and smaller employers have always been all over the place anyway in terms of what they offer.
Excuse me, a question about open enrollment. If a person moves from one state to another and the open enrollment period has passed, is there a mechanism for dealing with that?
Yes, yes. If you want to see how that, you want to wait for questions?
Yeah. If you don't mind, we'll do the questions afterwards.
Okay.
Thanks.
And I'm almost done. We have some now sort of, in my view, disconcerting inconsistencies with how rich our non-Medicare coverage is going to be compared to our Medicare coverage, when if you are a student of healthcare and healthcare students tend to use that ratio of beds per thousand and days per thousand population. If you look at days per thousand population, days per thousand in a hospital, and you look at that graph, you see that from about age 40 on, there's just an upward curve. And so with Medicare, we don't have unlimited hospitalization. We have unlimited benefit periods, but you can exhaust your hospital coverage if you don't have 60 days of not using Part A services. That's a discussion for another time. But we're not getting away from having different, a somewhat fragmented system, which is a larger concern. This is my last slide. I don't think there are enough moderate views of this legislation. There's either la-la land, it's all going to be fine, pshaw, and just the sky is falling. And there's not much in between. For all the reasons that I try to walk you through the history of this, my plea to anyone is we all have a part to play to try to make this work. We're running out of time. It's not just about an income transfer and helping out low-income people. I've worked on the hospital side of the business, the insurance side of the business, the physician side of the business, and now we represent individuals. But harkening back to working on the other sides of the business, we can't just continue to say to providers, our hospitals and doctors and all other providers, you know what, we can't afford to pay you what you need, just do the best you can. That has a price to pay as well. So we do have to figure out how to improve access, improve the delivery system, and reduce costs. Thank you.
Thank you. Okay. Well, good evening. Thank you so much for coming out tonight. My goal really is one is to give you an overall sense of what exchanges are, a little bit of context about how they're being rolled out nationally. The second is to talk.
Please.
Use the microphone. This is the first time I've been requested. Usually told me just talk less loud. The second is to talk a little bit about the exchange in Connecticut and how that's going to work, and basically the process for enrollment and such. And then the third is to talk a little bit about the vision and touch about some of the broader issues that it's not on. Is that better? Okay, thanks. And the third is to talk about the bigger picture, broader issues that Maura did such a good job describing. I always get such a kick out of hearing about the age 26 issue for students, because that originated with us in Massachusetts. And you know, there almost became a state competition for this because Florida, about 2 years after we introduced it in '06, raised the rates that kids could stay on their parents' plan to age 30. And then, not to be outdone, the Garden State of New Jersey decided to raise it to age 31. At which point you have to wonder, at least, how long are kids going to have to stay at home before they get a child? But there was a little competition, apparently. So let's talk a little bit about where we are in Connecticut. And Maura also mentioned this as well. We have about 9.6% uninsured in the state, or about 344,000. This actually puts us at the low end. When you look at states in the South in particular, it's not at all uncommon to see uninsured levels of 20%. In fact, 1/3 of the total uninsured in the country reside in 3 states: Florida, Texas, and California. It's 19%, close to 20% uninsured in Florida. It's 26% in Texas, and 19% in California. So, but if you look at that whole band of states, it's from Mississippi, Arizona, Alabama, and I've talked to the governors of most of those states in my prior life. It really all hovers around that 19% level. And that's an issue whether you can argue whether that's a good thing or a bad thing, but that's clearly the facts, and that's where we see high preponderance, of course, as a percentage of the uninsured. We have, our goal, quite frankly, is to reduce that dramatically. That's not going to happen quickly. It's not going to happen next year. It's not going to happen in the next 3 years. But over the next 4 to 5 years or so, I think it's realistic to bring that level down into the 2 to 3% range, which would keep us basically consistent to where Massachusetts is. Massachusetts is actually at 1.9. And frankly, would keep us consistent with the rest of the G20 countries. Because if you look at the industrialized world, no one's at 0% uninsured. So Switzerland, Holland, Germany and such are all in about 2%. So 2% seems to be the norm for the G20. And frankly, I think that 2 to 3 is realistic for us. But again, this is going to take time. And one of the challenges in the whole implementation of the Affordable Care Act, outside the fact that it is a somewhat irrational implementation because it's a 3-year IT implementation being done in 10 months, is just there's all these wild expectations about what this is going to do. And the reality is that it's going to be complicated. Medicare took years in order for that to stabilize. Medicare Part D, for any of you that either knew people or such that were impacted by that, took 3 to 4 years to stabilize. That's going to be the same thing with this. Unfortunately, because next year is an election year, it's going to be great fodder for people on the left and the right. So you'll see this quite a bit. We've got almost 600,000 folks on Medicaid in our state. With the expansion of Medicaid eligibility going up to 138% of the federal poverty level, we should be adding roughly 75,000 or so of newly Medicaid eligible folks to our ranks over the next couple of years. And in total, for next year, we expect somewhere in the order of 100 to 130,000 people of the uninsured being newly insured. So these would be folks in a combination of roughly 100,000 coming into the exchange and roughly 30,000 going into Medicaid. So what's an exchange? Well, frankly, an exchange is essentially a free market, pro-competition means to buy health insurance in the same way people buy other consumer products. So whether it's a smartphone, or it's a laptop, or looking to get an airline ticket, or buy a car, it's applying the same type of pro-consumer concepts of information transparency, enrollment simplicity, price comparison, all those same kinds of things that we value in other parts of the consumer experience to health insurance. That's essentially what it is. And if you look at data around consumer perceptions around health insurance, whether it's the stuff we did in Massachusetts, or the Pew data, or Kaiser, or RWJ, which is Robert Wood Johnson, you find a very consistent thing, which is in general, consumers find buying health insurance to be confusing, complicating, overly expensive, and they all think they're getting screwed somewhere. They don't know where. They don't know if it's the insurance companies, the brokers, where it is, the doctors, but they just can't believe something should be this expensive. And you can't blame them. I mean, if you look at the data in our state, 2009 was the first time where the average family premium exceeded the average family mortgage. The only difference is the average family mortgage doesn't go up 8 to 10% a year. So these are all the kinds of dynamics that are impacting people's frustrations around health insurance. So these are all very standard. Is the insurance exchange going to solve all that? Absolutely not. Does the Affordable Care Act solve that? No. It makes some dents, particularly in the migration from fee-for-service reimbursement to global payments and other types of paying for outcomes. And that's a big part of one title of the Act, which is Title III. There's a New York Times story coming out tomorrow that's actually documenting the impact of some of that on lower costs. Because we've had the lowest actual inflation in overall healthcare costs in the past 3 years than we've had in decades. So anyway, that's all some of the dynamics around it. So there's basically, the part of the goal, however, as I said, was pro-competition, is to try to get more players into the market. And in our state, beginning in 2014, is the first time we have a new not-for-profit entrant in our market in 26 years. And that's a company called Healthy CT, which is an insurance co-op created by the Connecticut Medical Society. And it's funded by the federal government. But that's going to be a new entrant on the exchange and in the market. In 2015, we're having a big not-for-profit from Massachusetts named Harvard Pilgrim come into our state. So, you know, so health reform is good in this regard. It's not a perfect law by any means. But to the extent that it brings more health plans into our market and they compete more aggressively for your business, that is a good thing. I firmly believe, and my experience both in Massachusetts and California has borne this out, that the more competition that you have in anything, be it health insurance or anything, it's best for the consumer. And so we want more health plans that come into our state. We want them to get into the marketplace. We want them to fight it out for your business. And that's the best way, in our experience, to have more competitive prices for you. So, it's finally, exchanges are brand busters. Traditionally, if you look at this historically, the institutions that have been the most resistant to healthcare reform have been the insurance companies with the biggest market share. Because, you know, everybody likes to talk about the free market and pro-competition and everything. But in fact, actually, nobody really likes competition. Monopolies are really a lot better. So this is true in insurance as well as any other part of the market. And that, again, gets to the reason that we want to have an environment which is conducive to more competition. Want to take a seat? Okay. So there are three kinds of insurance exchanges. And matter of fact, this will give you a little bit of insight. The exchange word now in Washington is now a bad word. They don't like that word, and it's for political reasons. We're now called marketplaces. So the E word is now verboten. Now we're called state-based marketplaces. But there's three kinds. There's one is a state-based, which is what we're doing in Connecticut and what 16 other states plus the District of Columbia are doing. This is the purest form of the Affordable Care Act. It's also the most complicated because it involves this really extraordinarily complex integrated eligibility IT system, which, believe me, you really don't want to know all about. It's too much sausage making for you, but it's very complicated and elaborate, and fortunately in our state we're making pretty good progress to getting it done. The second is something known as a federal facilitated marketplace or exchange. This is the default exchange. This is for the states that wish Obama were never elected, wish the Supreme Court ruled differently, wish Obama were never re-elected, wish this were like the last episode of Dallas, where it was all a bad dream. Those are for those things. And the third is something known as a state partnership. And that's basically a hybrid of the first two. So the federal government does a piece of the exchange, and the respective state does another piece. With respect to numbers, I told you there were 17 states doing the state-based exchanges, like Connecticut. And they're typically on the coasts. There are 26 states defaulting to the federal exchange, where CMS originally expected 5 or 6. And there are 7 doing state-based exchanges. So where Health and Human Services, or CMS, was originally expecting 5 or 6 states to administer, they're now going to be administering 34. So it's a very, very challenging time for everybody. You know, we tease, because we're considered one of the top 3 states in our development nationally. At least that's what they tell us, CMS tells us. That and $2, by the way, gets you a cup of coffee, but it's nice to hear it sometimes. Those folks in DC have got a big, big challenge bringing this thing up. And that's one of the reasons you may have read that they deferred the implementation of the Small Business Health Options Exchange until January 15. We, however, are one of 3 states that are going to be still on track to introducing that in 2014. So Medicaid expansion I talked about, moving up to 138% of the federal poverty level. That's about $14,400 for an individual. You know, I think about the default exchange for a second. It just reminds me of my prior job in California. I visited with the lieutenant governor of Ohio, and she's also the insurance commissioner, and is a member of the Tea Party. And I asked her what Ohio was going to do, whether they were going to implement their own exchange, and she said, no, we're not going to do that. And I said, are you going to default to the federal exchange? She said, no, we're not doing that either. So I said, are you going to secede? Is this going to be the Republic of Ohio? And she said, no, we're not doing that, we're just not going to do it. That represents, by the way, a big, big piece of the country. Like half of those states would just kind of hope this whole thing goes away. So this has got a whole other dynamic that's just going to be kind of interesting. Subsidized coverage, as Maura mentioned, goes up from 139 to 400% of the federal poverty level. 400% of the poverty level, by the way, that cap is about $46,000 for an individual and about $92,400 for a family of 4. And as Maura also mentioned, eligibility is now based almost exclusively on income. And it's the adjusted gross income line of your tax form. It always reads modified because there are all these kinds of really quirky details that could potentially modify your adjusted gross income. But to really simplify things, if you were to look at the AGI line of your tax return, that would be the line that would determine eligibility. And that eligibility would be potentially for either Medicaid, for tax subsidies, that goes from the 138 to the 400, or if you're above that 400%, you'd be eligible for unsubsidized commercial coverage. Okay, so this is a schematic of how enrollment actually works for an individual. And if it looks simple, it's because it actually is. Behind the scenes, you don't want to know. Incredibly complex. Front, consumer facing, it's pretty simple. It begins with an individual enrolling with, or rather entering some basic information. That will include such things as the adjusted gross income, which I mentioned, family size, zip code location. That's basically it. It's basically the kind of information it has. There are some other things, but in general, that's basically what is required. That information is then entered, and if everything went right, you click the enter button, and that goes into 22 interfaces between eligibility verification by the feds, among Treasury, Homeland Security and Social Security, and also at the state level with the Department of Social Services, Department of Corrections, Department of Labor and such, to verify in fact if what you entered is in fact true. After that verification occurs, you'll be then shown a series of plans. And the plans would be like Aetna, Anthem, Connecticut, Healthy CT, etc. And so you'll see the plans going vertically across the x-axis. On the y-axis, you'll see the benefits. And the coverage, as Maura explained, is divided into 4 metal tiers. Bronze, silver, gold, and platinum. For young people, and young, for me, gets defined differently every year. But the feds are defining it as 30 and below. They are also eligible to get something called a catastrophic plan. But for most folks, they're going to be able to choose one of those 4 metal tiers. And each tier represents a certain richness of coverage. And that richness of coverage, I'm just going to be a little technical with you for a second, so forgive me, is defined by an actuarial value, which represents the percentage of the total expense paid by the insurance company and the percent paid by you. For example, the bronze plan is a 60% actuarial value, which means that 60% of the costs are paid by the carrier and 40% by the enrollee up to a certain out-of-pocket maximum. Silver, 70%. So right, silver's the insurance company, 30% the enrollee. Gold, 20%, 80% by the insurance company, 20% by the enrollee. Platinum, 90%, you got it. And just for a little health reform cocktail chatter for your future weekends, my wife is responsible for the reason of the metal tiers. And the reason for that is because when I was at the Connector back in 2006, the executive director and I had this idea about creating these levels. And so being a good marketing MBA, he said to me, why don't you come up with the names? So I came up with these names like the Freedom Plan and the Liberty Plan and the Revolution Plan. And I used to run them by my wife before we went to sleep. And she used to say, bad idea, worse idea, you know. And finally one night she got so frustrated and she turned to me and said, look, you know, your ideas are all bad. Why don't you name it after the Olympics? Gold, silver, bronze. Everybody gets that and just be done with it. So that's her contribution to national health. But after that point, a plan is then selected. So the individual then makes a choice, and let's say, for example, I'll just pick on Connecticut for a second. Let's say they pick the Connecticut plan. So after picking the Connecticut plan, then they enroll. So then they start putting in name, social security number, dependent information, billing address, all the kinds of things that you would normally put in for an enrollment in an insurance plan like that. You then send a binder check, you press the enter button, that information is sent directly to Connecticut. Connecticut then takes your information, does not do any keying, it's loaded directly into their eligibility system. They issue you an ID card and an evidence of coverage, and you are insured for January. Now, probably your reaction is, that sounds way too simple, it's got to be much more complicated. And the reality is it's not. It's not more complicated. And the reason I can tell you that is because this is exactly what we did back in 06 and 07 at the Connector in Massachusetts, which is what the Affordable Care Act is based on. I don't care what Governor Romney said. And by the way, I started working with him. I mean, before he didn't know me, but I mean, I was in his administration. This is exactly what this is based on. It took the average enrollee in Massachusetts 22 minutes to enter information, compare coverage and costs, and enroll. Now, I think because of the tax credits, which are far more complex in the Affordable Care Act, we're predicting it's going to take about twice that long. And to help provide information to people that are going to have obvious questions about it, we're providing information both on the website, through an 800 number in a call center, through written documents and videos, basically trying to make something incredibly complicated as simple as possible. Because the fact is, folks, nobody really has that much patience for complexity. And one of the things that's also very different from communicating in 06 and 07 to 2013 and 14 is people actually don't read much anymore. So everything is pretty much going to be in video. Even in the application process, you'll be able to roll over a word like deductible, and it's going to take you to a video that explains what deductible is. That's the world we live in. So, I talked a little bit about the customer service functions. There is self-help, again, through the website, through calling our call center, and also, as Maura pointed out, brokers are going to be very actively involved in this. We've received very, very good support and interest from the brokerage community in Connecticut. There'll be such things as navigators and in-person assistants that are also going to be sort of community-based people that are going to be helping people understand the law and enrollment. In general, the in-person assisters tend to work a little bit at the lower income level, a little bit 250 and below. Brokers tend to work a little bit above that. So that's somewhat how the population is going to bifurcate with respect to that type of enrollment assistance. There's going to be 1 million people offering online help for this kind of thing because it's such a new market. So there'll be almost too much help. And part of the challenge is to make sure that the help is actually from folks that know what they're doing. And to that end, that's a challenge that all the people in my job are always a little bit concerned about, just because of the complexity of the law. So, what's the goal going forward? Well, going forward, there's some key things we want to do. One is, we want to make this enrollment experience as easy as possible. And I talked a little bit about what that looks like. I know that you're going to walk out of here saying that can't be right, it's got to be a lot more difficult, and it's not. And you'll see it when you come on the website in October. The issues around tax credits, complicated. And you're clearly going to want, as Maura said, get professional help on that, call the call center, talk to people who really know what they're talking about. Two is to lower the percentage of uninsured. One of the key metrics that people like me are going to be judged by. And by the way, as I told my wife when I took this job, this is a job where you don't win. This is a job where it's about degrees of losing. So we're just all trying to lose a little bit less, because this is where you actually make nobody happy. But one key metric that all the policy wonks and the press and others are going to measure us by is, did you actually reduce the percentage of uninsured? So did that 9.6 come down? And by what level did it come down? So that's an unknown. You know, like Maura talked about, frankly, having a $95 penalty is not really all that helpful. Now, in Massachusetts, we had $219 during the first year. And then it progressively went up to, now it's about $1,200. And the ACA does that to some degree, but it actually caps out at about $695 in 3 years. So, in any case, that's just an issue we have to work with. By the way, it's interesting, you know, Maura talked a little bit about the Young Invincibles, which are kind of the term coined for men and women under 30. It's actually not quite accurate because that population of young people are not really monolithic. The research that we did in Massachusetts showed that it really bifurcates by gender. So for example, young women, 18 to 26, did not need to be persuaded on the value of having health insurance. They had much more routine experience with the healthcare system. They valued it. What they wanted to know was, how do I get the best deal? I do not want to overpay. So you exchange, your job is to help me understand the best price I can get. Young men, a little bit different. Their view was, number one, health insurance got in the way of bare money. Number two is, they thought that they got sick, that they would make a bet that somebody would take them to a hospital where they would get treated, and then they could negotiate the price coming out. So it's very interesting how this is credible data. I mean, this was done with 450 young men and 450 young women. Which was why at the Connector, we actually used to market young men to their mothers. So we used to run a campaign on Mother's Day called Get Insured for Your Mother, but we didn't send it to the young men, we sent it to the mothers. And it worked extremely well. But what's also interesting was during that enrollment period for the Mother's Day campaign, there was this spike of the most expensive health insurance plans, because the mothers always bought the most expensive plan, because nothing was too good for John. But anyway, it's to reduce that level of uninsured is going to be critical. The third is more options and choice. We want to provide broad-based choice of product, but as I mentioned earlier, get more carriers into our market. We're delighted to have Healthy CT come in. We're going to be delighted to welcome Harvard Pilgrim next year. Again, more competition. The more competition, the better it is. Promote innovation. We have standardized plans by each of the metal tiers, but we're also giving the carriers the opportunity to create 2 customized plans per tier. So they can look at limited networks. They can look at accountable care organizations. They create plans based on patient-centered medical homes. They can do a lot of things to try to be innovative and creative and not just offer the marketplace the same old plain vanilla. Because frankly, folks, if you look at the plans being offered right now, it's a lot of plain vanilla. And this market needs shaking up a little bit, and hopefully be a little more creative. Finally, is to talk about the 800-pound gorilla, and that's cost. We have the 4th highest insurance cost in the country, with some of the strictest insurance controls, whether that's medical underwriting, pre-existing condition, the gender load, the 6-to-1 age band. We've got some of the most stringent underwriting controls, but some of the highest costs in the country, and that's just unsustainable. It's a job killer. It's unaffordable. And I'll tell you, I do these town hall meetings all throughout the state. And I can't tell you the number of people that come up to me and tell me how they're working 2 to 3 jobs to try to make a living, and then they're spending 20% of that income in health insurance premiums. One woman who was 63 came up to me and said that she and her husband have got a $10,000 deductible individual plan, $20,000 family, and they're paying $14.50 a month. So this is like buying a college education every year before they get any benefit. So that's the kind of thing that we have to do better. This is a very, very hard discussion. Does the Affordable Care Act solve all that? No, but it starts the discussion in a way that is going to be helpful. So anyway, with that, thank you very much.
Thank you, Maura. Great perspective, and thank you, Kevin. Great information. Questions? And what we're going to do is pass, because we're recording this for people, there are a number of people who could not be here. So we're recording audio, we're not recording faces and questions.
What is the procedure for somebody who moves into the state when it is not the open enrollment period? How do they enroll?
You want to go ahead?
Sure. So that's considered a qualifying event, and you would enroll as soon as you become a resident of the state. That would be similarly true for people that have a change in their life. For example, they have a child, or they get married. So the open enrollment period that Maura spoke to is initially 6 months. It runs from October 1st, 2013 to March 31st, 2014. And then as she also said, beginning in 2014 and going forward, it's the last quarter of the year. It's October 1st through the end of December. And to avoid the adverse selection she talked about, it's specifically defined within that period. It's one of the mistakes we made in Massachusetts, is we allowed rolling enrollments, which actually got to the point that Maura mentioned, where someone was uninsured, found out they needed surgery in May, got insured in March, and dropped it in August. So the AC, we ended up stopping that, and the ACA smartly did the same.
This discussion could come at a better time, because we've been on COBRA on what you would probably consider a platinum plan, and we're now going to buy a family insurance. And I think Darien is a bubble. My daughter was diagnosed with cancer in 2006. She's doing well. And there's nothing like being told in one breath, your child has cancer, don't ever lose your insurance, she'll never do it again. So Obamacare has been a blessing for my family. That being said, I have started talking to brokers, because we have to get individual insurance on June 30th. Are they allowed, some of them have been telling me, they are going to put her as a level 5 risk. They're actually going to charge more for her insurance versus the rest of us. And by the way, she's only insurable if my husband and I are insurable. So I don't plan to go to the doctor between now and June 30th, just to make sure I don't get anything. Is that still allowed under the Affordable Care Act?
It is allowed. No, it's not allowed. I'm sorry, go ahead.
So what do I tell these insurance companies now that want to put her as a level 5 risk and charge me more for her? She's only 11.
She's 11, so she is guaranteed coverage
Yes.
under the Affordable Care Act, but I thought they could rate up.
No, so for 2013, she can be put in that level because she's being underwritten because she's got cancer.
She does not have it now.
Okay.
She was treated for between 2006, 2008.
Okay, so you need to work with a professional that knows how this underwriting game works, because she's going to be subject to medical underwriting. In 2014, that goes away forever. So you're not going to have to worry about staying on COBRA. You're not going to have to worry about whether you see a doctor in June 30th, and you're not going to have to worry about whether your daughter ever gets insurance coverage again. You don't have to change states or anything like that, so that goes away. You've got a short-term problem.
You know what, let's just spend a moment on that though, since we still are in 2013. The Health Reinsurance Association is one guaranteed issue option in the state of Connecticut. So you still have that. Everybody has that in 2013. But what has happened in the last couple of years since the Affordable Care Act passed, you can go online and see Anthem rates, and they have stratified them into 5 different levels. And so there is difficulty in trying to predict what one might pay, because a child is guaranteed coverage, but there is quite a wide spread among those 5 levels, and you can't know where they will place your family member until you go through that application process. And I'm familiar with Aetna too. It's similar. It's just they've still got very few pages of rate sheets, but at the bottom, the same thing. We reserve the right to rate up. So someone in your situation should look at every option and see what's best for your family.
Well, I kind of laugh. I've spoken to 2 brokers. My choices are Anthem, Blue Cross Blue Shield, or United Healthcare. And I've told I could possibly get Cigna, but I don't know any Cigna reps, because you can't deal directly with the insurance company, apparently.
But have you looked at the Health Reinsurance Association?
I've never even heard of it until tonight. So.
Well, that's part of the problem, but
Yeah, okay.
that's Connecticut's high-risk pool. Let's talk afterward, I'll tell you.
The other point, which I think I'll mention quickly, is we do, here in Connecticut, we do have the Office of the Healthcare Advocate, Vicki Beltry. It is, I just learned this, it's not funded by taxpayer dollars, it's funded by the insurance industry. She's terrific at helping people solve medical issues. So, John.
She is.
Thanks, Terry. 2-part question. Do other states have this metals plan with multiple levels? That's question one, if they're involved with the exchange or the marketplace. And question two is, if you sign up on October the 1st, is the effective date, no matter what, January 1? Those are the two questions.
Yeah, so to take them backwards, the answer is yes, it is January 1st. If you enroll after December 25th, you then get moved into a different month. So if you enroll like December 31st, your effective date would be February 1st. The last date of open enrollment is March 31st, and that would be from May 1st, 2014 effective date. And as I said, that then it goes into this Q4 enrollment period going forward, all based on January 1 enrollment periods. So if you were effective, say if you enrolled in March 31st of 2014, effective May 1st, you're going to renew again in January 1st of 2015, and then every year going forward. And I'm so sorry, I'm tired, I forgot the first question.
The first question was whether the other states that are...
Oh yeah, all 50 are subject to the metal tiers.
So they will...
Yeah.
What about alternative health care and nature paths and things like that? I heard they weren't covered, or they're not legit. I guess I'm not getting hold of them.
Yeah, why don't you repeat it? I had trouble too.
I've heard that nature paths and alternative medical practitioners are not seen as legitimate health providers. Is that correct?
Well, I wouldn't say that's accurate. I can't say that those services would be covered through a product on the exchange. Do you happen to know?
Yeah, so it depends on what the insurance companies define them as. So if the insurance carriers define them as practitioners and providers, their services would be covered. The exchange does not define providers. The exchange is a distribution channel. So we leave the definition of that to the private market, to the carriers.
So there will be richer products available, and you would have to shop around.
Thank you.
I have a question. We just went off COBRA onto an individual plan, and we had an interesting experience with that. But our broker indicated that those on an individual plan, not through an employer, will have increased premiums effective January 2014. That because of the healthcare law going into full effect, the smaller plans, i.e. those who have individual plans, will experience higher premiums typically. Unless, no, that's not. Like with this exchange, how do I compare? Because it was an interesting experience. We ended up choosing Aetna. What I found really odd is that they will not give you the information. Like the underwriter is, in the back behind the wall, and they have service, they have customer service people just giving you like 3 or 4 word answers as to why you might get rated up. So I just don't, I can't tell, I can't tell what we should plan for in terms of cost starting in January.
There's a great deal of uncertainty about what the rates will be in January. They'll be available within months, but...
A couple of weeks.
Couple of weeks?
Yeah.
And how long will the approval process be?
To July 31st.
Till July 31st.
So, I'll have to say one other thing that I thought was really odd. Sorry, Maura, I know you were just trying to answer the question. Is that I'll give you a simple example of what Aetna did, which made no sense. My husband and I, we were both, none of us have any serious health issues. We were given, Aetna has this plan, premiums are quoted by age, right? So we got the standard rate. I have a daughter who has had acne medication, and they rated her up by like 30%. And I could not get an answer. That was one simple example. Their answer was the medication that that person was on the side effects. I had never heard of such a thing in my life. In the meantime, they raised, my husband and I were both, we're not in our 60s, but we're approaching it. We were rated at a standard rate, which didn't make any sense to me.
Well, let me comment on this.
I just sat there, it didn't make, to me, it's acting medicine versus, someone who's, kind of like me. I don't know, I just didn't get it.
This year is a time of real transition. And it's true, it's not possible to predict where the insurer might put someone in terms of their rate structure because they won't share their medical underwriting criteria.
It almost seems illegal to me, that they
Well,
can't, what I mean? Like, it almost seems arbitrary,
And it will all change in 2014, although the flip side of that is, in this environment where there's been medical underwriting for so many years, there's been nothing cheaper for young, healthy people. I mean, I can tell you, I have 4 children in their 20s, and 3 out of the 4 of them, we got individual coverage in 3 different states when they were between jobs in their early 20s because the rates were so cheap for good coverage relative to COBRA. Because think about it, the rates were age-rated, these are young, healthy people, and the COBRA rates were based on a population of older employees. So it really does depend, it has depended, this is all changing now, on a number of factors, but it was much easier a few years ago to predict would you get coverage or not, and the rates were published so you could see where you would be. But we had an experience with a client we thought was incredibly healthy, except she was in the most expensive age cohort in today's world, in her early 60s. And Aetna denied her for what we thought was a very minor issue. They wouldn't share, they said the procedure she had was too recent. And when we asked, well, how far in the past did it have to be? Oh, that's proprietary. Then applied to another carrier and they accepted her and they rated up. But they rated up into, say, level 3, not level 5. So we are in an era of real transition, and it will be simpler in 2014, but you should still do your homework because, as Kevin said, we're going to have new players in the marketplace, and people should learn more about what their options are.
I'll come over there in a minute. One more question over there.
So who would be using the insurance exchange? Would it be people that are individuals getting their own coverage? And I work, I'm a financial advisor, I have clients that pay a lot of money through their employers, and they pay $1,000 a month. So, and are all these companies going to be the insurance exchange? Would it basically be an alternative for everybody to at least go and get a quote and see, the insurance exchange versus what I'm paying through my employer or through my individual plan?
So the target market for the enrollees in the exchange are individuals, they're small businesses, they may be categories of employees that businesses may not be covering anymore, such as part-time workers, such as certain segments of Taft-Hartley organizations, unions, for example. Some employees for whom the employer-sponsored coverage, otherwise known as ESI, employer-sponsored insurance, exceeds 9.5% of their income, they would be able to go onto the exchange and also be eligible for subsidies. So it's kind of a broad group. If you were to say who you think that the primary targets are, they're individuals and small businesses. But it's not quite that simple. And it's not quite that simple only because some businesses, large companies, are actually reconsidering if they want to cover certain segments of the populations that they used to cover, such as part-time workers. I'm speaking before a group of very large employers in our state on Friday, in large part just to talk about that very issue. So one thing I would just tell you about exchanges in general, whether they be through the state or through private exchanges, is that they enable the 401k of health insurance. something known as defined contribution. And I think we're going to see over the next 5 to 10 years a fair amount of migration to these types of vehicles.
We're back here for a question. If you're on Medicare and have a supplemental insurance, let's say, if you're on Medicare, if you're on Medicare and you have a supplemental, let's say like Blue Cross Blue Shield, will there be changes in that supplemental policy or will it stay the same?
No, there shouldn't be.
This is really about pre-Medicare.
Okay.
Yeah. Thanks for asking that question, though, because there's a lot of confusion about that.
And there are interesting issues there. I mean, in Connecticut, you can always get a supplement even if you didn't get one when you first turned 65 or you first retired, but there's a waiting period. And will that continue? Some of these questions are unanswered, but if you already have your supplement, it's not going to change because of the Affordable Care Act.
Do you think that it makes sense to apply for insurance under a medical rating? Like, do you think that will that still exist privately? Like, say Costco has insurance, I mean, will that go away, that type of thing? In other words, if you're somebody who could qualify medically for a good rate, would companies maybe be looking for you as like a plum right now?
Well, for the reasons that some of the other members of the audience gave far more eloquently than we, that's going away. So there's not going to be a medical underwriting system anymore. Will Costco still offer insurance? They might. I'm not really sure about that. I tell you what, one thing I think we are going to see. We're going to see, I think, the beginning of more minute clinics offered by firms like CVS and others that are going to take advantage of a new population of the insured. Another thing I think you'll see is that more primary care physicians are going to have a lot of basic primary care be performed by RNs and physician assistants and licensed practical nurses to take up more volume. We saw that in Massachusetts. And sometimes they do a better job than the primary care doc.
I've got actually two questions. I'm a small employer, and we really want to offer insurance and had put a plan in place about 8 years ago. Now we're finding that not only the premiums have gone through the roof, or we're having difficulty paying for them, but the employees don't want to take the insurance because they can't afford to even pay half of it. So we're hopeful of being able to utilize, as an employer, can we go onto the exchange and try to buy a group plan for our employees? And then my second question is regarding where one goes. We're trying to run a business. We're not insurance experts. I'm feeling completely overwhelmed trying to find what information this is all about and how to find a good plan and where we go. And then also I've got an aging mother, an 84-year-old, that I'm looking for some sort of consultant to help me straighten out what the Medicare additional supplemental stuff is. Where does one go to find consultants to help, such as you guys, that have this kind of information and can tell us where to go?
Speaking to the affordability of health care coverage, I'm a business owner too, and it's something we all struggle with. That's why I was trying to convey that we're not really going to bring down the cost of premiums until we bring down the cost of the delivery system, that 85 cents of the dollar. And the Affordable Care Act does try to get to that through different payment structures. Are we going to see that in year one? No.
I'll
But
get Medicare before we see it, right?
No. But the vicious cycle we've been in is paying largely on a fee-for-service basis. And so we've been in this madness of, okay, we can't afford this system now, so we're going to pay you less per unit, which incentivizes all types of providers to do more tests, more admissions, more visits. And it's just, we haven't done enough to break that cycle to get to value. And everybody's got a part to play in that. And if it were easy to figure out, somebody would have figured it out by now. But there's a tremendous amount of care that is provided that isn't good. It's probably even harmful. And we've got to go after that. We've got to go after different ways to keep our sickest, poorest people outside of ERs, as though this is the home away from home. And that's not going to solve your problem, but there's a lot of good brokers and consultants out there who can help you. And as of October 1, the not exchange, marketplace, Medicare's different. Our system is fragmented. So many people who know the non-Medicare side of the world don't know the Medicare, but you've got all kinds of resources through the local social services department, the area agencies on aging. My book is a good, this last 70 pages of my book address the transition to Medicare. And there's a lot of good information. Medicare and You, the book that's published every year by the government, is online. Just go to medicare.gov.
If I'm talking more about actually a consultant where I can go in and say, I've got an 84-year-old mother, and this is her policy, would you review it and tell me if she has reasonable coverage and what do you recommend? And they would evaluate different plans and then say, these are the 3 I think are good, choose one.
You would go to a broker who would be paid a commission on the supplement that they recommended and you ultimately purchased for your mother, or you would, we work on a fee basis. So we don't take commissions. We're insurance consultants who only make money because we charge clients. And I'm not here to promote myself. So. We're following the mic, sorry.
Okay. Obviously, this is an issue that everyone could talk about for months on end, but I think something that's being missed is what is actually being done to bring down the costs of healthcare. In that you take a look at the cost of the drugs, you take a look at the cost of an MRI machine, you take a look at the cost of the tests. The actual prices of these things, they keep on going up and up, and you hear these stories about folks will go to like Costa Rica to get their dental work done because it's a lot cheaper. You know, like we can discuss the coverage and the insurance and blah blah blah, but I think it's the cost is being missed.
And charges. I have to say, if you want to read some of the articles that I've assembled for this evening session, you can take a page from over there or we'll email them to you. But it is true, we have costs and charges that are out of whack. So it's both an issue of what is the unit price and how many units are we putting through the system. In the United States, we have every type of irrational sort of underutilization and overutilization of services, which exacerbates this problem. And no one's got a clear-cut solution to it. This act tries to move us away from fee-for-service, which is partly the culprit, but there's no silver bullet here.
So if I could just compliment what Maura had just said, there's actually many sectors. There's Title III of the Act actually addresses costs in a fairly substantive way. In addition to payment changes, it also promotes accountable care organizations. It promotes integrated delivery systems, which we really don't have in Connecticut, but some exist. Dartmouth-Hitchcock in New Hampshire, Geisinger in Pennsylvania, the Cleveland Clinic in Cleveland, University of Michigan in Ann Arbor, the Mayo Clinic in Minnesota. There's a number of these very sophisticated integrated delivery systems which coordinate both primary and specialty care in a way that have proven to be much more cost effective. So if you look at their PM per member per month costs, they're actually going down. So there's actually more substance than I think a lot of people recognize in the law. People focus on the stuff they understand the most, which is maybe the part that interests you maybe the least, but it's coverage and premium cost. But there are 9 titles in the law, and one is pretty substantive on cost.
Could I just add to that? I worked for a number of years as an executive with one of those integrated delivery systems, and if life had been different, I would have been a lifer with them. I have great affection and respect for the Kaiser Permanente organization, but that model should have been able to undercut the market enormously. And any organization, even a nonprofit healthcare organization full of people who want to do good works, in our situation, I can tell you, we could cut days per thousand, which we did, taking enormous amounts of money out of what we were paying hospitals. But you've got all of these other stakeholders, employees, pay me more, give me more vacation days, add to my pension. So I think that's a much better model than fee-for-service, no question. But some of the impact we need to have in the future is probably spending money outside of the healthcare system to reduce costs in the healthcare system.
I had a follow-up question related to costs and pricing. We are an individual plan. I look at the bills when they come in, and I notice that the price negotiated between the insurance company and the provider is typically a half of the list price for a given service. Help me understand why that price isn't going to go up. Where's the incentive for the insurance company to keep negotiating lower special rates for their insurance?
Right now we have 50 million uninsured Americans. It's like 16 Connecticut's, right? About. And the people with individual insurance are left with no clout, really, right? The government's...
No, the insurance company negotiates a reduced rate if you have insurance. So I have Anthem. Anthem negotiates rates.
I thought you were talking about what Anthem pays the provider.
Right. So if I go on, say, a bronze plan, now all of a sudden I'm going to be paying 40% of that. And if insurance company A is very good at negotiating low prices, but insurance company B is very bad at negotiating low prices, but offers me a low premium because their prices are higher.
But they can't do that.
Yeah.
So
why not?
Because if their costs are higher, they're not going to be able to undercut insurance company A. If insurance company A, I thought you said, has better contract prices with providers than insurance company B. Was that what you're?
Yeah.
Okay. And I thought your question was insurance company B could be charging less than insurance company A. Maybe I'm getting my A's and B's mixed up.
Me too.
Okay. The carrier that cuts the best deals are going to have the lowest costs because they've cut the best deals.
Unless they have a sicker population.
It's a fixed percentage of the price of what they have to pay out.
But if they have a sicker population, they get risk adjustment.
Exactly. So we didn't talk about risk adjustment tonight.
That's not good.
And that's very complicated.
Well,
but
I just think they're kind of confused. It's not that complicated. It's just it's confusing. This is what it is. If you had a utilization of 80% of premium by one carrier, and another carrier has 120% of their premiums goes to claims, one's 80% of, and the other's 120. The idea around the risk adjustment is the carrier that had the 80%, the really low, the really healthy people, they've got to pay a percentage of their earnings to the company that had the sicker people enrolled to level out the playing field. Now, why are you shaking your head? Oh.
It's like such a cat and mouse game.
Well, the idea is that...
Like, how are we supposed to know that when we pick a plan?
No, but that's not something you have to worry about. This is between the insurance companies. Doesn't involve you. But the idea is that, we wanted people to participate in the market, and if they got selected against by the math, right? They got randomly selected with high utilizing people. The insurance company, I don't think, should be penalized for that, right? Just as if someone got the luck of the draw and got really healthy people and they get excess profits, you really wouldn't want them, So it's the idea is just try to make it more competitive for all the carriers.
Is that in the marketplace or overall?
No, it's in the
For the
marketplace.
exchange?
Yeah, it's in the, yeah, it's for the exchange population.
Only for the exchange?
Correct. And that's because the newly uninsured are mostly going to be going into the exchanges. We're kind of getting late, aren't we?
Yeah.
Gonna wrap up.
I
You wanna
just
say-
have one question. How are you marketing the exchange or marketplace to low-income people? Let's say people that are in public housing, people that have language barriers, people that aren't as interested as this group. How is it being how are those people being accessed?
It's a couple of ways. First, it's through community representatives. One of the things that we have now that we didn't have back in '06 of the connector, actually there are two things. One is we've got much better data, and the second is we have much better technology. So for example, we know that 89% of the uninsured in our state live in 7 towns. And we happen to know the zip codes of those people within the town because of the census data. It's not don't think your privacy is being interrupted, or don't send letters to the editor, which will probably come.
You're on Facebook, right?
Yeah, that's right. That's right. Exactly. But we've got data now that we can actually micro-target to people that we didn't have before. So back at the Connector, we used very broad-based advertising, particularly using things like Around the Red Sox and such, which is like a semi-religion in Massachusetts. We don't have to do that now. So we're using community organizers within each of those towns. They're identifying for us community representatives within certain ethnic groups. Because if you've got a community champion of one ethnicity, that doesn't necessarily mean that he or she is going to be effective with another ethnicity, even within the same town. So I'm oversimplifying, but we're using really community people to help identify. Then we're using houses of worship, community activists. That worked extremely well for us in Massachusetts. We used the Greater Boston Interfaith Organization that actually went on Sundays, and the congregations went door to door to help enroll people on Sundays. And so we're learning from a lot of things we did in Mass.
All right, one more question, and you can certainly stay, gentlemen, with his hand check.
Thank you.
Mine is related to people who work for small businesses.
Yeah.
As I understand what you're setting up is you can either go as an individual if you decline what a small business may provide if they provide something. Is that an accurate statement?
It's not. It's not completely accurate. The employee has to have a situation where the contribution charged by his or her employer exceeds 9.5% of their income.
Okay, so if I'm a small business owner, which I am,
Yeah.
I'm going to be notified of these various things so that I can put a plan together, for example, for my employees if I wish to do that. And then they have the ability to say, yes, I'm going to be involved with your plan, or no, I will not be involved in your plan.
Just like now.
If they're not involved in the plan, then they still have to do something on an individual basis or pay a fee.
Correct.
And then as a small business owner, I'm off the hook for whatever the...
Correct.
And what do you do about spouses in those cases? Because you did say that they're not being covered. Do they also have to do something about coverage for themselves?
Yes, so the law is a citizen law. It's not an employee law, it's not an employer law, it's a citizen law. So what the law is saying is that all eligible citizens 18 and above, 18 to 65, have to have health insurance. And that there are certain vehicles that they can get it. Now one vehicle could be you as an employer. And you've just identified some ways that you may or may not be able to provide insurance for your employees. And if you do provide it, there are means, depending on the income level of the and affordability of the coverage you provide, means for that employee either to pick that coverage through you or potentially to waive out and buy coverage through the exchange.
So if, for example, I decide to cover employees and I say, yes, you can also cover spouses,
Yes,
then they could opt for that as opposed to going out on their own.
that is correct.
Well, that's all I'm-
That's correct. Thank you. That's about it.
Thank you all very much. I think if there's some other questions, would you mind staying another couple of minutes? I know it's a school night, but, so other questions, come on down. But I certainly want to thank Maura, Carley, and Kevin for being back.